real question becomes is what is the optimal time to introduce these agents? And that's really where the great debate lies. For instance, if someone has very indolent disease, has low volume disease, they could remain stable for extended periods of time, and that there really is no need to treat patients such as these with somatostatin analogs. And if they develop progressive disease or disease that's symptomatic, at that time it's reasonable one could potentially treat with somatostatin analogs. On the other hand, if someone has more extensive disease, it's reasonable to start somatostatin analogs up front. The other question that I think most physicians grapple with, do we continue somatostatin analogs when patients have disease progression? Do we not? And how does one manage that? I think in general, a reasonable approach is to discontinue the drug if patients clearly develop progressive disease when they're on somatostatin analog. On the other hand, if patients have hormonal secretion or they have carcinoid syndrome, it's reasonable, since these analogs have demonstrated activity in the management of carcinoid syndrome and the management of these hormonal syndromes. I think it's reasonable to continue somatostatin analog therapy. There's also no benefit to switching somatostatin analogs. So for, let's say, if you're on octreotide, if you have disease progression, switching to lanreotide may not necessarily benefit the patient.